sound to the level of this voice. It will match the level of sound in the film you are about to see.
This is the Neuropsychiatric Institute on the campus of the University of California at Los Angeles. Here, Dr. James Simmons, a psychiatrist, is studying the way in which learning affects the behavior of autistic, emotionally disturbed, or mentally retarded children. Get interested in investigating reinforcement therapy.
Well, it's been increasingly clear in the field of psychiatry that there are a large number of individuals who don't respond favorably to traditional therapeutic approaches. These groups include, for example, the schizophrenic child, the mentally retarded child and adult, and the chronically regressed schizophrenic adult. Consequently, it's been necessary to look in other areas for the types of treatment approaches that might prove effective for this group.
Why do you think traditional techniques haven't done so well with these patients?
In part, it probably is because the individuals who have to care for all of these patients have been trained in such a way to view sick behavior as the thing which they have to take care of. And in many instances, the destructive behavior, the bizarre speech, and so on like that are actually reinforced by the environment. And you could say that the hospital itself supports the sick behavior.
Well, how would you go about changing sick behavior?
If behavior is really partly a result of what the environment expects, it's not too difficult to conceive of an environment so structured that the expectations of the patients are more directed toward normal behaviors, toward socially acceptable behaviors, and this is the basis of this particular approach.
And your approach is based on learning theory, isn't it?
Yes, if it is true that part of treatment is learning new behaviors, then one could use a learning theory approach to this problem. And if you were to use a learning theory approach, it would then be well to utilize what is current acceptable learning theory, which has to do with reinforcement theory, and thus use a reinforcement therapy or operant conditioning type of therapy. This happens to be the area of expertise of Dr. Ivar Lovas, who is the director of the project on treatment of childhood schizophrenia.
Is the application of learning theory something new here, Dr. Lovas?
No. Research on the principles of learning has taken place in every major American university for 50 or more years, so that the principles of learning are relatively well understood, and we have this advantage of being guided by a set of principles that has some clarity. The application of learning principles, though, for treatment and for education of mentally retarded children, that is rather new. It's only a few years ago that Dr. Ted Ayon at Anna State initiated a program based on reinforcement theory for the treatment of abnormal behavior. Since then, we've had a number of programs all over the country, but they still have the quality of inquiry and a quality of research associated with them.
What has this research told us about behavior?
Well, in the most general sense, I would say that behavior which leads to a reward or the termination of stress or discomfort, those behaviors are strengthened. Behaviors which results in no reward at all or discomfort, those behaviors are weakened. So when we structure a treatment program along these lines, what we have done is to actively reward behaviors which we judge to be socially appropriate. And we have not rewarded, and here at NPI we have explored actual discomfort for the patient if he engaged in behaviors which we judge to be socially inappropriate.
Doesn't this mean that you're asking the patient to take on a large responsibility?
It does. And we feel quite strongly that without this responsibility, without the person experiencing the consequences of his behavior would in fact disintegrate, and so would the functioning of the group in which he exists.
As to the patient's accepting responsibility, how does this affect the method of treatment?
Well, the most important aspect of the treatment, I think, would be to define what behaviors it is that you want the patient to be responsible for. And then secondly, what the consequences are that you invoke for those behaviors. The treatment becomes then the structuring of a special environment, a special society.
What will we see here at UCLA?
Well, here you will see the program that we initiated with the four first children that we took into treatment. They are very sick children, profoundly disturbed, and those children who had been in treatment by the time we saw them had not improved with that treatment. Pamela was 9. She was extremely psychotic.
You like my shirt there? What is that? Is that my stomach?
Her speech was entirely echolalic. She showed no interest in her environment, but repeated over and over the bizarre behavior so characteristic of autism. Ricky was 7 and rejected our attempts to show him affection. Like Pam, he was echolalic.
What's your name?
What's your name?
How old are you, Ricky?
How are you?
Billy got no comfort from people. He actively fought them off. He was 6 and he had never talked. Billy had violent tantrums and often injured himself. Like Billy, Chuck was mute. At the age of 6, he still didn't know how to play. He spent most of his time rocking.
Hug, yeah.
These children were so unresponsive to people, we couldn't use social or verbal approval as a reward. But since they were all good eaters, we could use the primary reward of food.
Hug, 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 hug.
Starting at the simplest level, we had to teach them to play with each other, to respond to affection, and how to talk. The job became one of creating a total environment in which the children could learn. In this film, we will consider only the program for teaching the children to speak. However, that program demonstrates quite well how the principles of learning can be applied in the teaching of new behaviors. We proceed to teach language in a step-by-step fashion. First, we ask the children to imitate sounds which others make. Then we teach them to call objects by name, then to ask for things, and gradually then in a step-by-step manner we approach the teaching of conversational speech.
Chucky couldn't imitate the sound so we had to help him. We did this by closing his lips. Good, Chucky. Just as soon as he showed the desired behavior, he got his reward. It is crucial to give the reward immediately. Notice that we help him less now. The hand is only on his chin. Good. Good, Chucky. That's good. Good. Good boy. Mmm. We don't close his lips anymore. We always remove our direct help as soon as possible. When the child behaves on his own, he learns the most. Chucky. Be. Be. That wasn't close enough. If we had rewarded him that time, we would have taught him the wrong thing. We will try again and see if we can't get a closer approximation. Be. Chucky. Chucky, look at my mouth. My mouth. Be. That's right. I want you to look at my mouth. Okay. Be. That's right. Be. Be. Chucky. Chucky, look at me. Look at my mouth. Be. That was close enough, so we rewarded him this time. Good. That's pretty good. Mama. No, Chucky. Mama. Mama, Chucky. Mama. See how inconsistent Chuck's performance is. Behavior you have just started to build will be weak, and you should expect many errors in the beginning. Here, Chuck. Mama. No. Mama. Good, Mama. Good. Good boy. That's good talking. That's very good. Bill E.
Oui.
Bill E.
Oui.
Bill E.
Oui.
No, look at me, Billy. Look. Bill E.
Oui.
Bill E.
Oui.
No. Billy.
Papa.
No. Bill.
Papa.
Look at me, Billy. Billy? The word Billy was too difficult to get. When any behavior is too complex, we have to break it down into its parts and put it back together later on. Let's do this. Ba.
Papa.
Ba.
Papa.
No. Ba.
Papa.
Look, Billy. Ba.
Papa.
Ah.
Ba.
Good.
Oh.
Ba.
Ba.
Good. E.
Li.
Good. Billy.
Oui.
Good. Billy.
Oui.
Good.
Papa. Papa. Good boy.
With continuation of training, imitative behavior becomes strong and more consistent.
Good.
Baby.
Baby.
Good. Ball.
Oh.
Good. Boy.
Oh.
Good. Papa. After months of treatment, Billy can repeat words, but he doesn't know what they mean. Baby.
Baby.
Good. The children don't know when to use words or how to use them. They cannot yet describe the world which they are beginning to enjoy, but they have to learn to tell us about that world. So our next step is to teach them what things are called. What is it, Chucky? Bed. Big. Good. What is this? Good. That's right. Very good. Very good. What is this, Chucky? Juice? Good. What is this? Good boy. What is it, Chucky? Toast. Good. Very good. That's the boy. That's Chucky. That's my boy. What's this? What is this? Corn?
Oh.
Good. Very good. A? Good. 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 Egg. Good. Very good. Delete. What is this? I. Good. What's this? What is this? Mouth? Good. Good. Eye? Good. What? Good. I what? Good. Very good. That's a good boy. Very good. Corn? Corn? Good. I want corn. Very good. Good boy.
What? 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 Blow? Okay.
Now we teach them to ask for what they want.
What do you want? What do you want? I? Oh, okay.
Okay, now what do you want?
I want to take paper apple.
All right. That was good talking.
Do you want me to chase you? Ask me.
I want to go take me.
Okay. On your mark,
Yeah.
go.
Pamela, what's your name? What's your name? What's my name?
Pam and Ricky were echolalic. They already imitated, but far too much. So our first step with them is to teach them when not to imitate or echo by ignoring or disapproving of this incorrect behavior. At the same time, we teach them to answer correctly, for example, by telling us their names.
Look at me, Pamela. What's your name? No. Pamela. Yeah. What's your name? Good. What's your name? What's your name? Pamela? Right. What's your name? Yeah. What's your name? What's your name? No. What's your name? No. Pamela. What's your name? What's your name? Good. What's your name?
Mine.
Oh, Ricky.
Ricky.
Good. What's your name? Ricky. What's my name?
Mine.
No, Dr. Lubin.
Mine.
No.
Dr. Wolver.
What's my name?
Mine.
Ricky, look at me.
Dr. Wolver.
That's right.
What color is that?
Pamela has already learned to identify colors, in this case, yellow. But here she manifests once again her bizarre symptoms.
What color is it? What color is this, Pam? What color is it? Look at the crayon, Pam. What color is it? What color is it, Pam? What color is it, Pam? Look at the crayon. What color is it, Pam?
If further learning is to take place, we cannot permit this behavior to continue.
What color is it?
You tell. Look at it. What color is it?
Yellow.
Very good, Pam. What color is that, Pam?
Yellow.
What color is this, Pam?
Yellow.
Very good.
Pamela, put the block on top of the box.
We have to teach them things other than the names of objects. They have to learn the meaning of relational terms. For example, on top of, beside, and inside.
Put the block beside the box. See? Beside the box. Put the block beside the box. No, Pamela. Put the block, look at the block. Pamela. Pam, look at the block. Put the block on top of the box. See? Look at the block. Okay. Now you do it, Pamela. Pamela, stop it! Pick up the block and put it on top of the box. On top. Good. What am I wearing, Pamela? What am I wearing?
They have to learn the meaning of I, you, and he, and what is mine, yours, and his.
You're wearing a blue sweater.
That's right. Good girl. Pamela, who is wearing the red shoes?
I am.
That's right. What are you wearing, Ricky?
I'm wearing clothes.
What clothes? What kind of clothes?
Blue shirt.
Yeah.
Blue pants.
Yeah.
Socks.
Yeah.
Tennis shoes, black and white tennis shoes.
That's right, that's right, that's right. Pamela, who sleeps in Ricky's bed?
Ricky does.
That's right, good girl. Who comes to see you on Tuesday and Thursday?
Mommy and Daddy.
That's right.
Tell me about breakfast, Pam.
I have toast and jelly.
What else, Pam?
They have to learn to remember and tell us what they remember.
Ketchup.
Good. What did you put ketchup on?
My egg.
Eggs. Good girl.
Hello, Pamela.
Hello, Mrs. Duma.
That's a girl. How are you, Pamela?
Fine. Hello, Mrs. Duma.
I'm fine. That's very good, Pamela. Good girl.
The children understand some words now, and so we start to teach them to converse with us. Notice the mechanical, robot-like quality of these early conversations. Also notice that we have made it easy enough for them to be rewarded.
Yes, I am, Pamela. Ricky, what's your name?
Ricky.
That's good.
Mine. What's your name?
Joan. That's good, Ricky. Good. Where do you go to school?
UCLA.
That's good. Ask me where I go to school. Say where?
Where do you go to school?
UCLA. That's good, Ricky. Very good. That's good.
Read this and do what it says, Ricky.
Now that the children know what some words mean, they can be taught to answer factual questions. Here, Ricky looks forward to giving the right answer. We don't have to use food as a reward anymore. Our approval has become important to the children.
On the chair.
Very good. Are you standing on the chair?
Yes.
That's good. Are
No.
you sitting? Are you sitting on the chair?
No.
Are you standing beside the chair?
No.
Are you standing on top of the dresser?
No.
Are you standing on top of the chair?
Yes.
Good boy. Ask me some questions.
What is this?
Louder, Pamela.
What is this?
That's a circle, Pamela.
What color is this?
That's a red circle. Very good, Pam. That's a good girl, Pammy. That's very good. Look at me. That's a smart girl. Ricky, ask me some questions about the things.
What is this purple circle?
Yes.
After a while, asking questions becomes fairly easy.
Is this a block?
Yes.
Is this a closet?
Yes.
Is this a dresser?
Yes.
Is this a dresser?
Yes, that's
Is
good.
this a floor?
Yes.
Is this a blanket?
Yes,
Is this a closet?
that's good.
Is this a closet?
Good, that's good.
Is this a dog? Is
Yes.
this a slippers? Is this a melon?
Yes.
Is this a dress? Is this a bucket?
Yes.
Is this a towel?
Yes, good boy. That's good.
I love you tons and tons.
Tons and tons.
Now that many of the parts of speech are there, the children can begin to talk with us and tell us what they experienced.
Lickety-clack, lickety-clack, lickety-clack. Go the railroad track.
That's right. What else does the train say?
Toot toot.
That's right.
What do they wear on their feet?
Swan fins.
That's right. What do they wear on their backs?
Aqualung.
Good. What's inside the aqualung?
Compressor.
Good. Where do they go? Hey, look at me. Where do they go?
Go swimming in the lake.
That's right. What do they do underneath the lake? Hey,
Skin divers.
that's right. What do they look for?
Look for buried treasures.
That's right.
Underneath the ocean.
Right.
This is how Ricky was a year ago.
Good job.
Look at him now. He has begun to respond to affection and to enjoy some of the things that other children do. By teaching these children new behaviors, we have brought them step by step towards a more rewarding existence. They still have a long way to go, but now that they can communicate with people, other forms of treatment can be used to help them.
Rainier School in Buckley, Washington is a residential school for the mentally retarded. In this setting, a research program is going on which aims to teach retarded children academic subjects using the reinforcement principles and behavior modification you have just seen applied to psychotic children. The program was initiated by Dr. Sidney Bijou, a psychologist, with a research staff consisting of Dr. J. Bernbrower, whom you see here, Mr. John Kidder, and Miss Cecilia Tague. Dr. Bernbrower, what do most of our institutions do to teach the mentally retarded?
Most institutions have a fairly large educational program. which is run along traditional classroom techniques with some variations designed for the retarded. Unfortunately, the success of these programs has not been what most people would have hoped for.
How did you approach teaching mentally retarded children?
In designing a teaching program for the retarded child, first of all, I would, and we did, discount the traditional preconceptions of what a retarded child can and cannot do, or what he can learn or cannot learn. What we teach are pretty ordinary things: reading, writing, and arithmetic at the primary level.
What's different about the way you teach these things?
The two major characteristics of the teaching program are first that we treat each child as an individual and prepare instruction for him in a stepwise fashion that will take him at pace that he can absorb. And secondly, we use reinforcers that are meaningful to the child, and we dispense them meaningfully. We use candy, toys, and other goodies that most children like. To get these, however, they have to earn marks. These are tokens for achievement. The children really look forward to their classes. Once inside, they quickly get ready to start the day's work. The advanced group begins by picking up folders containing a series of lessons to be completed during the session. Since the lessons are individually designed, each child can work at his own speed. Each of them keeps a daily log of his work, first writing his name on it and then setting his watch by the wall clock. Incidentally, the children are very proud of their watches, which they have earned by learning to tell time. Now each child demonstrates and maintains his ability to read a clock by writing his exact starting time on the daily log sheet. Ron is working with a stimulus presenting device which allows us to present new words to him in a systematic way. This is the sight vocabulary part of the reading program. For each correct response, he gets immediate reinforcement from his teacher. He has a very good attention span now and makes few mistakes. One of the boys, whose IQ is only 45, is learning 6 new words a day with this procedure. Mary is a Mongoloid child and the youngest in our program. She is doing a picture phrase exercise to maintain the vocabulary she has learned in the sight vocabulary program. We are pleased to see Mary working steadily on her own. Over a period of several months, she has been taught to do so. Since children in the beginning group are only assigned one task at a time, the teacher will look over Mary's work as soon as she is finished and give her marks for correct responses. Mary knows that she can exchange a page of these marks for a reward after the class is over. Jimmy is learning to follow written directions. He is a step ahead of Mary in reading skills. During each sight vocabulary session, Jimmy learns 2 new words, and here puts them to use in a practical way. This is truly meaningful reading. His concentration on his work is remarkable for a boy who can't keep his mind on anything for too long outside the classroom.
In box 6 put 4 green cars and 2 blue.
Arnold is wrestling with arithmetic. Before he entered the program, it was extremely difficult for him. But because we encouraged him to use his environment, including his fingers, He can now do addition and subtraction very well. This is Lee, one of our advanced students. He has progressed to the point where he can study sight vocabulary entirely on his own. This stimulus presenting device is considerably more sophisticated than the one Ron was using earlier.
He is big, but she is little.
He is big, but she is little.
Drink all the milk.
Drink all the milk.
At the end of the school day, all of the work is marked.
Okay, Lee, you ready to trade?
Yeah.
Give me the page. Okay, Hugh, you all ready to trade?
Yeah, what do we get?
Let me have a page.
Well,
What do you see in there?
I think I'll have my job for today.
All right.
They take together. See ya.
Bye.
Y'all ready to trade? Got a full page today? Good girl. What would you like? What looks good? Okay, that's fine. See you tomorrow.
Okay.
The rewards of learning can be enjoyed by anyone. The staff is just as pleased with Mary's progress as she is with her candy.
At Patton State Hospital in California's San Bernardino Valley, a reinforcement therapy program has been set up to help long-term chronic psychotic patients. It is patterned on the pioneer work of Dr. Ted Ione, the first to apply reinforcement theory to the treatment of mental illness. Dr. Otto Garricky, superintendent and medical director of Patton, was instrumental in getting the program underway.
As Dr. Simmons said earlier, one of the problems facing the staff of any mental hospital is the sizable group of patients who don't seem to respond to any of the various forms of therapy the hospital has to offer. Here at Patton, some of these treatment failures, as we call them, have been in the hospital anywhere from 6 months to 30 years.
What led you to try reinforcement therapy with these patients?
Yes, we felt that this type of therapy has two obvious advantages. First of all, it deals with the patient's immediate problem, the behavior which causes the community to reject him. Secondly, the principles of reinforcement therapy are relatively easily learned by the nurses and technicians who must apply them daily on the ward.
Reinforcement therapy does require special training for ward personnel, doesn't it, Doctor?
Yes, it does, but its practical aspects are relatively easy to grasp compared to the traditional psychodynamic techniques. Dr. Hal Schaefer, one of our research psychologists, gives a 6-month course in reinforcement therapy techniques for nurses and technicians. We find that after completing the course, these people can make a significant contribution to the patient's improvement.
One of the people now working with reinforcement techniques is Nurse Dovey Farish, who supervises Women's Unit 10.
I've been working at this hospital for 11 years in psychiatric nursing, and in the past I've found that our programs, we thought they were good programs, but there's been something missing. We tried to do everything for the patients. They had no part in their own treatment. I think the patients know that we care about them. We don't tolerate inappropriate behavior. We try to help them change this behavior and try to guide them, but they soon find out that this is a chance for them to get up and get out of the hospital, and many of them had given up hopes of leaving the hospital.
En mi huerto brilló la esperanza, La esperanza que alumbra el camino de mi soledad.
On Unit 10, most of our patients have been in the hospital for several years. But now that we are rewarding them for improving their behavior, we are seeing some real changes. Instead of sitting off in a corner somewhere or pacing up and down all day like they used to, some of our patients help out with the ward work. Of course, improvement in behavior is not unique to our program. The essential thing is our systematic use of reinforcement principles to bring out and reinforce appropriate behavior. There are many types of behavior which these patients will have to learn if they are to live successfully outside the hospital. As part of our program, improved behavior is rewarded with poker tips. We call them tokens, and the patients use them as money to pay for their room and board as well as for the various ward privileges. Some appropriate behavior is rewarded immediately, but patients also get some of the tokens they have earned at a regular pay call. Because we encourage the patients to think for themselves, they are asked to explain what they have done to earn their pay.
And I told Gladys Conroy that I lost my comb.
And you get paid for socializing.
Yes.
See, you overpaid me.
I did?
Yeah.
How much did I overpay you?
Well, let's see. I get 119 and you gave me 112. Let's see. You gave me I gave her 112 and I've got 10, 20, 30, 40, 50. Yeah, that's how much you gave me.
This patient was deliberately overpaid. She'll get to keep the extra tokens as a reward for figuring it out.
Will that help you out any?
Sure.
Some patients spend their tokens at our vanity shop. They enjoy their beauty treatment and later they will be rewarded for looking nice. This helps them to learn that keeping neat and attractive is a good thing. Everyone pays to go into the dining room at mealtime, and they are seated according to their progress in acquiring acceptable social behavior. Some eat at comfortable tables with tablecloth and flowers. Others have to accept much less elegant conditions until they earn the right to eat at a better table.
2 tokens.
I earned 2 tokens this morning.
Well, where are they?
I don't know.
Well, I can't let you have lunch without tokens.
Here's the cherry pie.
2 tokens.
I don't have 2 tokens.
Yes, they do have cherry pie for lunch. It has whipped cream on it.
Oh, give me some.
2 tokens, Sally.
Let me in there.
How much do you pay
Let
for your
me in
meal?
there.
How much do you pay for your
Let
meal?
me in.
How much do you pay for your meal?
2.
2. Well, where's the other token?
I haven't got it.
Well, you better get one.
Oh.
Come on, Nellie. Go on, Nellie. Sit down. I'll have to charge you for that. I'll charge you for every time you hit me.
I haven't got 2 tokens.
Well, why don't you go get some tokens? Have you sat around all morning not done anything to earn tokens?
Yes.
Well, that's too bad. You'll have to go without your lunch.
Well, take that one, please.
You know what? You do something to me. Now. And I'm not kidding. Play around. That's it. Come on. Get it going. The other way. Reverse it.
These patients are watching Jacqueline Lane's daily exercise show. If they exercise along with the program, they get reinforced immediately, especially if they're overweight.
Slow down slowly.
There's Ellie. She's making sure she won't miss her supper, too.
Inhale. Slow down. Right, waist in this time. Stand tall. Inhale. Exhale.
Hi, Ellie. Do you know what that's for?
No.
Well, it looks to me like you're reading.
A patient who takes an interest in what's going on in the world will have an easier time when she leaves the hospital.
Ruthie, you can't sit in the bed tonight. You didn't have enough tokens to pay for it, so you have to sleep on the cot here.
No.
Ruthie, you don't have enough tokens to earn the bed tonight. You have to sleep on the cot.
Yes, I do.
Let's get up and get on the cot, Ruthie. You can't sleep in the bed tonight.
Yes, I do, too.
You don't have enough tokens.
Yes, I have enough.
Let's get up, Ruthie. You don't have enough tokens for
I
the
do
bed.
still have enough.
Ruthie, you were fine, so you have to sleep on here. You don't have enough tokens to buy your bed.
Yes, I do.
No, let's get up.
Okay, well, I get up. I'm gonna get up, but then...
This patient hasn't earned enough tokens for a bed, and the only bed she can have for free is a cot. Right now, she's a little stubborn and confused. The nurse will explain and re-explain until she understands.
No, it's not yet. See, sir, you can't sleep on the bed.
I'm not sleeping here.
Okay, but you can't have the bed.
Well, that's all right, too.
We found in the past in this program that no patient has to sleep for any more than 1 or 2 days on a cot under those conditions, because the tokens then acquire their value, and the patient learns that it's very easy to earn them, and does so.
Still there. You're going to stand better, you're going to get up without crying. Do I have to go to work this afternoon? Are you supposed to be at work? Yeah. You better get up and go. You have to pay 3 tokens if you stay on the bed. Oh. What you going to do? Okay, thank you.
Cigarettes are a powerful reinforcer. Patients must learn by them. Some patients work very hard on their behavior to earn the use of our smoking room. This is one of our social learning groups where we get together and talk with patients. Their verbal behavior during these sessions give us a good clue to their progress. A patient doesn't get a token just for talking about her problems. She's rewarded only when she says something that shows she's actually trying to deal with them.
Perhaps it would help the people know you a little better if you told us a little bit about yourself this morning.
If my family had more knowledge, they would understand it better. Break a leg, a medical doctor sees it gets well. But if you have a mental breakdown, you yourself are the one that needs to help yourself more than anyone else.
Well, in about 2 weeks, I'm going to a family care home in San Bernardino, and there will be 4 girls at this family care home, and they have a swimming pool, and we'll let the patients use the pool. And after I get acquainted with the home and the family caretakers, I plan to get work.
It's a little early to say what a research project like this will mean in terms of the rest of our hospital will get along in the community. Still, we have seen that behavior can be changed for the better through our reinforcement program, and we are planning to keep on looking for ways to improve it.
Sin ti no podré vivir jamás y pensar que nunca más estarás junto a mí. Sin ti, ¿qué me puede ya importar si lo que está lejos de mí es quererte olvidar? Sin ti no hay clemencia en mi dolor, la clemencia de mi amor te la llevas por fin. Sin ti no podré vivir jamás y pensar que nunca más estarás junto a mí. Sí.